thank you very much for inviting me to speak today. That was a really interesting talk, and I'm sorry about the technical difficulties to start. But I'm very excited to talk to you today about ovarian cancer genetics and how we've managed some of the setting up of mainstreaming in the UK. So just to remind everybody, most of our patients with ovarian cancer unfortunately present at stage 3 or 4. And certainly in the UK, where between 75 and 80% of our patients will be stage 3 or 4 at diagnosis. And despite our best efforts, around 80% of our patients will relapse and will ultimately die of their disease. When we look at ovarian cancer, it is a huge problem across the world. It is essentially the most deadly of the female reproductive organ cancers. But it is one which is potentially able to be targeted to reduce the rates and prevalence in the community, because around 15 to 20% of all of the ovarian cancers we see are caused by an underlying inherited gene alteration. And therefore, if we have the opportunity to identify those with ovarian cancer who have one of these underlying gene alterations, as well as making sure that we're giving them the best possible treatment, we also then have the possibility of preventing others in the community from developing cancer and over time reducing the burden of this cancer in the community. When you look at ovarian cancer, and any histopathologists will be aware that ovarian cancers under the microscope look very different, and we see clinically that the different subtypes of epithelial ovarian cancer behave very differently as well. Now, it's really clear when you start to undertake molecular profiling on these patients just how different they are. If we look at high-grade serous ovarian cancer, which is the most common of our epithelial cancers, you can see that TP53 mutations are almost ubiquitous in the high-grade serous patients and routinely reported in between 95 and 99% of all high-grade serous ovarian cancers. We find BRCA1 and BRCA2 mutations in around another 20 to 22% of patients on tumour testing. And then they also have high frequencies of NF1, RB1, and the other HR repair gene defects. But this is very different when you look, for example, at the low-grade serous ovarian cancers, which look under the microscope much more akin to mucinous. We see KRAS, we see BRAF, and we see HER2 in both the low-grade serous and the mucinous patients. And of course, these patients are much less sensitive to chemotherapy. At the other end, we have the clear cells, which are predominantly driven by things such as ARID1A or loss of P10, which causes the same functional defect as ARID1A mutations. But we also start to see PIK3CA coming through in CTNNB1 as well. And finally, endometrioid, which is really a bit of a mixed bag of all of the others. We can see some BRCA1 mutations coming through there. We still see some ARID1A, we see a little bit of P10 and PIK3CA, and in the high-grade endometrioids, we also actually see a small proportion of BRCA mutations as well. Now, in terms of the original genomic profiling was done, in the Cancer Genome Atlas work, they looked at the profiling of ovarian cancers, but the only ovarian cancers that they looked at were high-grade serous ovarian cancers. So most of the data that we have actually comes from studies such as this. So almost all of the tumours that have been profiled to date have been predominantly high-grade serous. And what we can see here is that of these, the BRCA1 and BRCA2, both germline and somatic mutations, are present in around about 20% of the patients. And then we start to see other defects in the HRD genes, which together make up almost 50% of the patients. So you can see that in a large proportion of our patients will have these potentially targetable mutations with drugs affecting the HRD system. Then you have a small number of those which are such as NMR, CCNE1, which may possibly cause some degree of HRD mutation, and then a whole host of other ones which are not involved in the HR pathway. But you can see with BRCA alone, we have about 20%, and HRD in total about 50%. And this is increasingly important for us when it comes to treating these patients. In terms of the ovarian cancer journey, this has changed quite a lot since I first started treating ovarian cancer, but some parts of it are still very much the same. We have the patients present with the symptoms of ovarian cancer, most of which tend to be stage 3 or stage 4. We confirm the diagnosis, we stage them, we undertake a biopsy. But what is different now is that we tend to get straight in with BRCA testing. Now, for us in the UK, we currently undertake germline and somatic testing in parallel, and I'll talk for the reasons about that in a little while. But essentially, as soon as the patients hit the oncology unit, they have germline BRCA mutations discussed with them, and as soon as we get a biopsy that confirms high-grade serous ovarian cancer, we send that off for tumour testing. And then the patient begins their first-line treatment. So in our unit, most of those with advanced disease, so 3C or 4, will start with neoadjuvant chemotherapy. Those below that will usually start with primary surgery and then have adjuvant chemotherapy. But it's really important when we start this that we know upfront which sort of maintenance treatment we will be giving these patients. So for us, the earlier we get the BRCA results in, the sooner we know whether we would be giving these patients bevacizumab added into their chemotherapy or whether we would be giving them a PARP inhibitor at the end of treatment. So realistically, by the time the patient is having their first or second cycle of treatment, we need to know so that we can select the right treatment outcome for them. And then, of course, the other thing that has changed most recently has been the maintenance treatment at the end of first line. So up until about 18 months ago, if patients required maintenance treatment, they were given bevacizumab. But of course now for those with a BRCA mutation, either somatic or germline, we're able to offer them PARP inhibitor maintenance once they've finished their first line treatment based on the SOLO-1 study. So those patients who aren't suitable for maintenance treatment, either because they have contraindications or because they have an early stage of disease, will go back on to follow-up, and then at some point, of course, the patients will relapse. When we first set up mainstreaming, although we were keen to get testing done as quickly as possible in the patient pathway, it is fair to say that a lot of patients who were starting to relapse and had not been offered BRCA testing were suddenly being offered BRCA testing at this point. And again, this was about treatment outcomes. So at this point, we had maintenance PARP inhibitors available for those platinum-sensitive recurrence. So again, it was vital to get this testing done for the patients who had previously missed out, so that we knew as soon as possible whether or not they were going to be suitable for that. And then we go obviously on to platinum-based chemotherapy, plus or minus Avastin if they're not going to be suitable for a PARP inhibitor. And then, but if they are, they then go on to maintenance PARP. Those without a BRCA mutation have their maintenance treatment with Avastin, and then those who don't require a maintenance treatment will go on to our active surveillance, and so on and so forth. So it is really important that we get that BRCA testing done as quickly as possible so that we can start to make the decisions as early as possible as to the optimal treatment. For us, although we could potentially start, for example, Avastin and then switch to Elaprib if the patient was found to have a mutation, it isn't an ideal way to do it. We only get one go with Avastin, so if we've already used it up for one cycle, that then means that the patient can't have it at a later date. So it feels like a bit of a waste to delay testing and then have a negative impact on the patient's treatment options. But it's also really important when we're having a discussion with patients about prognosis, and it's really important when we're talking to patients about the pattern of disease that they will get. And I've always said when I first started the mainstreaming program that almost every new ovarian cancer patient that I see asks me the same questions when they're first diagnosed. The first one is, do I need chemotherapy, and if so, will I lose my hair? The second one is, am I going to die from this? And the third question that they always ask is, what does this diagnosis mean for my mother slash sister slash daughter. And I would argue that all of these questions can be better answered by knowing upfront whether or not someone has a BRCA mutation. In terms of the implications, I'm able to tell my patients with a BRCA mutation that they are much likely to have a longer life and they are much likely to have better remission. They have longer responses to platinum-based chemotherapy and increasingly now have other treatment options which would not otherwise be available. In terms of family, of course, if we find a patient with a BRCA mutation, we are then also able to roll this testing out to their family members. And I have many family members where an initial BRCA test on someone with ovarian cancer has led to the early diagnosis of other family members with pre-malignant lesions or early breast cancers that we have picked up specifically because of a BRCA mutation in an ovarian cancer patient. And of course, this is helpful when we start to talk to patients about their likelihood of responding to chemotherapy, both in the first line and also in the second line. Having a BRCA mutation makes these patients much more sensitive to platinum chemotherapy. This diagram is from the ALSOP study, which was looking at patients who had a diagnosis of ovarian cancer and were tested irrespective of BRCA mutation status. They found across all patients with ovarian cancer, 12% had a BRCA mutation. And when they started to look at response to treatment, you can see that in the patients with a BRCA mutation who had their first relapse, 86% of them responded again to platinum if it had been more than 6 months. And you can see the sort of breakdown here in terms of how they were treated, whereas the BRCA wild type patients who'd been more than 6 months had a lower response rate at 68%. We always talk about patients who had less than 6 months before they relapse as potentially being platinum resistant, but you can see that in those who had less than 6 months before their first relapse, 15% of them still responded to platinum if they were BRCA mutation carriers. 31% of those who were BRCA wild type were platinum resistant when they first relapsed. So you can see that the chances of being someone who responds is much higher if you're a BRCA mutation carrier. And then, as well as platinum, we also most recently have all of the PARP inhibitors. So at this moment in time, we have access over here to 3 different PARP inhibitors. We have olaparib, based on evidence from SOLO-1, SOLO-2, and Study 19, which allows us to treat patients for first-line maintenance, platinum-sensitive relapse in the second or third line, and also with patients with pancreatic and prostate cancer with BRCA mutations. We have niraparib, which is currently able to be provided to patients with relapse disease as per the NOVA trial. And then we have rucaparib, also for patients with platinum-sensitive relapse. And the striking thing about the 3 relapse studies is that you can almost superimpose the curves, and the hazard ratios are almost identical across the 3 studies, although the patient characteristics are very slightly different. SOLO-1, of course, is the only one which is currently licensed and approved in the first-line maintenance setting, and this was based on SOLO-1. Now, the really exciting thing about SOLO-1 is that patients who went into this study had first-line platinum-based chemotherapy, and then at the end of chemotherapy, if they'd had a partial or complete response, were able to start either olaparib or a PARP inhibitor. Sorry, olaparib or placebo. Patients who went into the study who were disease-free at 24 months this year were stopping the olaparib. But what you can see is that actually after that occurred, the curves don't come together. And we still don't have an actual progression-free survival because there are not enough patients on olaparib who have actually progressed at this point in time. So we are extremely hopeful that these patients who are all advanced patients, stage 3 and stage 4, probably have a high number of potential cures amongst them, which is something which we certainly wouldn't have envisaged several years ago. So this is really a game changer. Now, when we've been looking at who should be offered testing, traditionally genetic services offer genetic testing based on the family history. But actually family history is a really rubbish way of identifying who is going to have a mutation, because most of the studies of patients with ovarian cancer and a BRCA mutation show that between 40 and 50% of mutation carriers will not have any relevant family history. And this is particularly true of those who have inherited it through their father, because if a woman inherits a BRCA mutation from her mother, it is likely that her mother will have had breast or ovarian cancer herself, and people are much more likely to take notice. But if the mutation has been inherited through several generations of men, then there may not be very many women who have had the mutation who will show up with a cancer. And we see this also with our breast cancer study, where again we started offering testing based on age at diagnosis and histological subtype. And in fact, around 40% of those patients did not have a family history. So if you rely on family history to identify your ovarian cancer patients for testing, you will miss around half of the patients. So we now have a whole range of guidelines to support who should be offered BRCA testing with ovarian cancer. And these are based on the studies over the last few years that have shown how poor family history is as a marker of a mutation, and also as we've started to see more and more indications for treatment in those with a BRCA mutation. So the ESMO and ESGO guidelines both state that testing for BRCA1 and BRCA2 is recommended for all patients with non-mucinous ovarian cancer. ASCO recommends that all patients with epithelial ovarian cancer should have germline testing for BRCA1 and BRCA2, and if they do not have a germline mutation, they should then have somatic testing, and that this should be carried out at the time of diagnosis, whilst SGO, the Society of Oncology, have suggested BRCA testing for all patients with epithelial, ovarian, tubal and peritoneal cancers, even in the absence of family history. So all agreeing that family history should not be used to identify these patients, and ASCO going that one step further to say this should definitely be carried out at the time of diagnosis. But the earlier we pick this up, the earlier we can get on with treating the patients, and we can identify who should have what treatment. And this has probably been the biggest change that genetic services have had to get used to. Because actually, in the days gone by, genetic testing was carried out on people with cancer, not because it would have a particular influence on their cancer treatment, but because you wanted to inform the family whether or not they had a risk. And actually, the idea that we would now start informing patients of treatment options based on testing has meant that the days of being able to wait 3 or 6 or 12 months for results is just not feasible anymore, because if you're doing this testing to aid treatment, you need to have it in a clinically feasible time frame. And the earlier you can pick this up, the earlier you can get on with giving the patient the best possible treatment, and the earlier you can identify her relatives with mutations and potentially stop them from developing cancer as well. So this has now been picked up by many people around the world. So again, we've had alterations to the ESMO and ESGO guidelines in 2017, suggesting this be undertaken at diagnosis. Australia put out national guidelines in 2015, which suggested testing should be carried out in diagnosis, although they were a bit more restrictive about who should have it. And ASCO, as you saw, coming in 2020, saying that this should be undertaken at diagnosis. Now, when we test for BRCA mutations, there are 2 main types of mutations that we can test for, and these do require different testing and have different implications. The germline mutations that we're all used to, which are the inherited ones, come from a parent present from the time of conception, and we usually test for in blood or saliva. But in particular in patients with ovarian cancer, around 5 to 7% of patients who do not have a germline mutation will have a somatic BRCA mutation. So these are not inheritable and are present only in the tumour, but are also relevant for treatment because the studies such as SOLO-1, SOLO-2, Ariel and NOVA all included patients who had somatic mutations in their BRCA cohorts. And POWER1
which is one of the more recent ones, came out, which was looking at Alacrib and bevacizumab, actually undertook HRD and BRCA testing on all the patients who went in for BRCA carriers. So this proportion of BRCA carriers is higher than we would see in the general population. And that's partly to do with how they set up the study. But again, if you look, you can see 29% of patients in Power 1 had a tumour BRCA mutation, and another 19% had a different type of HRD mutation. So again, just on 48%, or around half of the patients in the study who were considered HR deficient. So somatic testing can certainly increase the number of patients who benefit from PARP inhibitors over and above the germline testing. There was a study from MD Anderson in Houston which looked at just undertaking tumor testing on patients. They found 19% of patients had a BRCA1 or 2 mutation, and keep in mind that this will be a mixture of both germline and somatic. When they did subsequent testing, they found nearly 2/3 of them were germline and 40% of them were somatic only. So this shows you that by adding in somatic testing, you end up with a larger population of patients in which you found a mutation who could potentially then go on to treatment. So this is something that's been looked at a lot, and in fact there are a number of countries around the world, including those who often have more limited access to genetic counselling or more limited access to germline testing, who may opt to start off with tumour testing as a first screening test for the patients. And there's a range of reasons to do this, and also the fact that you don't need to take consent before you start this. So this involves taking a biopsy or undertaking upfront surgery, so primary debulking surgery, a core biopsy if they're inoperable, or taking it at interval debulking if you're starting with neoadjuvant treatment. It's really important how you fix the tumour. Fresh frozen or a DNA-friendly buffer is required, so a neutral formalin buffer. You need about 10 slides worth of tumour to get enough cells from this, and then you can undertake testing. So you need a pathologist who's on board because you can't have an overfixed tumour. You need a surgeon who's either going to, or an intervention radiologist to undertake your biopsies or to give you enough nice tumour on this. And you need someone who can run the testing for you. So it requires several people to be involved in the pathway. One of the questions that patients always ask, and one of the questions that clinicians have always been really keen to look at, is does it matter whether the patient has a germline or a somatic mutation in terms of their response to treatment? And we know that actually the patients with somatic mutations do better than those who are germline wild type, but slightly worse in terms of long-term survival than those with a germline BRCA mutation. But when it comes to their response to PARP inhibitors, they seem to be relatively equivalent. And I say this with the knowledge that actually in most of the studies, most BRCA carriers were germline rather than somatic. So in many of the studies, they weren't able to do subgroup analysis and look at this correctly. These are the ones that had decent numbers of the somatic BRCA. But for example, Solo 1 had only 2 somatic BRCA carriers and the rest were germline. So as far as we can tell, somatic mutations have similar PARP responses to germline, but we can't be 100% sure. So one option, as I said, that's been looked at by many places is to start with tumour and then look at germline. And there are pros and cons with both of these. So the thing to realise is that no matter which test you do, you will miss some patients. There are large deletions and duplications which make up between 10 and 15% of all inherited mutations with BRCA1 and BRCA2 in populations around the world that cannot be detected in tumour, and that's to do with fragmentation of tumour. So if you do tumour only, you will miss a proportion of your inherited BRCA carriers. If you only do germline, you'll miss that 5 to to 7% of patients with a somatic mutation. So there isn't a perfect test. But by and large, if you start with somatic, you will pick up most of the germline as well as all of the somatic patients. So if you were only to do one test and you wanted to find the largest pool of patients with a treatment point of view, somatic is the way to go. If you're concentrating on finding the biggest number of germline carriers, then germline first would be the way to go. The two main methodologies that are used initially was Sanger sequencing. So Sanger sequencing was the gold standard until we developed next generation sequencing, but it is time and labour intensive and it sucks up a large amount of DNA. You need to undertake MLPA alongside Sanger sequencing to pick up large duplications and deletions, but you can do Sanger sequencing on either tumour or germline sampling. Next generation sequencing is now the way that we do most of our testing. It's high throughput, it's much cheaper, it's much faster. You do need bioinformatics people, and it's more expensive to set up because most of the machines are more costly. But most certainly in the germline, you can detect large genome rearrangements with next generation sequencing, although not with tumour because of fragmentation. So, as I said, when you're setting up these sorts of pathways, there are lots of different people that you have to have buy-in and have to have involved. At some point, a patient needs to consent for this. Now, in our pathway, this is undertaken by some of the oncology team or the surgeon, but in many places it will still be a genetic counsellor or a geneticist. If you're starting off with tumour, you need a pathologist who will prepare the tumour and get it reviewed, mark the slides and send it off for testing. When you're doing germline, you need someone to take the blood and prepare that. For both of these, you then need the preparation work in the laboratory, you need sequencing and the data analysis before somebody gets to a report at the other end. And along the way, this means that you have to have your oncology team, your surgeons, your pathologists, your geneticists, your scientists, your bioinformaticians, all involved to get to the end where you have a patient report or two. There are two different, slightly different classification systems. Essentially, the main thing to realise is that each has class 3 or tier 3, which are variants of uncertain significance, which I was interested to hear about the rate in India. We see higher rates of VUS in all populations that have had less testing because many VUSs are ethnicity specific. And then you'll have pathogenic and likely pathogenic at both ends in terms of somatic and germline, and non-pathogenic or benign and likely benign at both ends of the germline and somatic one. So in terms of the recommendations, our recommendation is that patients should receive this testing as early as possible. So for us, that means diagnosis. We undertake this on all patients with invasive epithelial ovarian cancer. That includes fallopian tube and peritoneal. We don't take borderlines, mucinous or low grade because they're not BRCA-driven characters, and we undertake it on patients irrespective of age. For us, we do some somatic and germline in parallel, but this differs around the world. Some do somatic first then germline, others do germline first then somatic. But the testing should involve the full extent of BRCA1 and BRCA2 by a certified lab, including large rearrangements and deletions in the germline, and ideally this should be undertaken using next generation sequencing. And for us, we would anticipate a turnaround time of less than 4 weeks as being clinically relevant. There isn't a definitive way as to how you should do genetic counselling. This is also done by many different ways around the world. For us, this is predominantly undertaken by the treating clinician, but we still have some patients who go through this with genetic counsellors. But the problem with this is that there aren't very many of them, and there is often a long wait to see them. They're seeing their treating oncologist at the start and then every 3 weeks whilst they're on treatment, so it provides an excellent opportunity to undertake this testing, but you do need to train your clinicians, and the same is true of nurses. There have been several studies that have looked at alternative ways of delivering this, such as telephone testing or online, And again, this is cheaper than face-to-face genetic counselling, but you still need someone at the end of the telephone, and you also need patients to answer the phone. And unless they're locked down, that is sometimes quite difficult to have happen. So you've already seen some of the slides previously, but we set up our mainstreaming program back in 2012 and started delivering it in 2013. And what happens is that all of our patients with non-mucinous ovarian cancer come to their oncology appointment, they get given an information sheet, they have a chat with their treating clinician, and if they wish to go ahead, they sign consent and provide a blood sample. These results come back and are interpreted by the genetics team, and the patients and their clinician then receive the results, usually by mail. Those without a mutation do not need anything further. Those with a mutation or a VUS come to the genetics team within a week or two for further discussion and a discussion about how their family can access testing. We always left in this option, which was if a patient required additional information or had questions that the oncology clinician was not comfortable answering, they could still be referred to the genetics team. So we have tested, we've been running this for over 7 years. We run it as breast cancer as well as ovarian cancer, and we have now set it up in over 18 countries around the world as well as across the UK. I won't go through this one because this was discussed very nicely by Dr. Luna before, but just to say that based on our testing, this was also set up in Australia, and I helped them do this a few years ago. And again, they used a slightly different way of doing it by having a genetic counsellor embedded in the gynae oncology team, who could then present the patient when they came to clinic, and then have the patient receive the results from the specialist and be referred on to the genetic counsellor for further follow-up if the mutation was identified. It also worked well for them because they had enough genetic counsellors to be able to have someone sitting in clinic. Whereas I think we worked out that in order to have a genetic counsellor sitting in all of our ovarian and breast clinics at the Marsden, we would require an additional 7 genetic counsellors just to do that alone. So embedding a genetic counsellor can be used, but you have to have enough resources. So this does not work for those who don't have much in the way of access to genetic counsellors and for whom there is a long wait to see genetic counsellors, because actually it can be quite a waste of time to have a genetic counsellor sitting in a 4-hour clinic and only seeing 1 or 2 patients, particularly when there are long waiting times elsewhere. So just to finish off, testing ovarian cancer patients is vital, and we undertake testing of all of our ovarian cancer patients irrespective of age and family history. If you undertake the testing early on at diagnosis, it means you can use this information in all of your future decision making. Tumor testing is the only thing that will detect both germline and somatic, although keep in mind that you will miss a number of germline mutation carriers if you only undertake tumor testing. And of course, the main reason that we've seen rapid adoption of this both around the UK and worldwide is because of the PARP inhibitors moving into first and subsequent lines of treatment. So I'll stop at that point and thank you very much for listening.